Welcome to UPMC Sports Surgery Clinic's evening for hikers and walkers. I'm Fiona Roach. I'm the Business Development Manager here at the Sports Surgery Clinic. Any of you that don't know us, we're just 10 minutes from Dublin Airport and just off the M50 and the M1. So we're one of the leading private orthopaedic hospitals in the country. We specialise in joint replacement, hips, knees, shoulders, also spines, foot and ankle, and hands and elbows. So really any of the joints in the body. Also soft tissue injury, such as ACLs and that kind of injury. We have 7 theatres here, also over 100 beds with a state-of-the-art physiotherapy and sports medicine department, which is in a building just 2 minutes up the road from us. So this evening, we're going to have 2 speakers. So there's David and then Professor Brian Devitt. Now, David Ray is going to talk about reducing the risk of injury while walking. David's going to join us after his presentation for a live question and answers. So you're going to see a tab there, ask a question. So please ask a question. We will endeavour to answer them all. And we'll probably group some of them together if a lot of them are similar. So there's another tab there for if you want to make an appointment or you need any information after the talks tonight. Also, as I said, we're with UPMC now, so there's another tab there if you want to learn about them. They also have sports medicine centres around the country and hospitals in Waterford and Kilkenny and Clane. So we're going to start with David's talk tonight, and I'll join you afterwards for the live Q&A.
Thanks, Fiona. Good evening, everybody. My name is David McCrea, and I am a senior physiotherapist working at SSE Sports Medicine Department. And I'm going to talk to you tonight about strategies that you can employ to reduce the risk of injury for walking, hill walking, and hiking. So I just thought I'd start by actually looking at the gait cycle initially. So it's always good to have a good understanding as to what is happening during the gait cycle and what the demands on our body are for this. So you can see here, it's broken down into a few different phases. The first 2 phases are really a phase where you're trying to absorb energy. So the heel strike, where we make contact with the ground, and then we progress to a flat foot. During this phase, the muscles and tendons in the lower body are really trying to absorb the energy and stop our foot from just slapping hard onto the ground. Once we move into the next phase, which is the mid stance and push off phase in the middle here, this is when our muscles and tendons are contracting to generate some power to actually push us away from the ground and propel ourselves forward into the next step. And then finally, we have the swing phase, which is the final 3 diagrams here. This is when the leg is off the ground. And what we have is the muscles in the hips lifting and bringing the foot into position for the next step. So it's a series of muscle contractions in different ways that is happening time and time again as we walk further, longer, and then this changes as we start to walk up and down hills. So then I thought it would be a good idea to have a look at the anatomy of the foot and ankle in particular, but have a look at the muscles and tendons that are responsible for allowing this movement to occur. So here we have a diagram of the foot and ankle anatomy. We can see it's a combination of bones which articulate with one another to form joints. Those joints are then held together by ligaments. And then you can see the pink and white structures on the diagram here are our muscles and tendons. Our muscles and tendons are what allow our joints to move. So within the foot and ankle, we have quite a lot of muscles and tendons, and all of them play a slightly different role during the gait cycle. So we might touch on a few key muscles and what they do and why they're important. So the first one is the muscle at the front of our shin here called the tibialis anterior. Now, this is almost like an endurance muscle. When we hit the ground with our heel, this muscle is working hard to absorb that impact and stop our foot from just slapping onto the floor. So every step we take, this muscle is really working quite hard to control the movement. On the inside of the ankle, we have a series of muscles and tendons that run into the foot here, called the tib post and the FHL. On the outside of the ankle here, we have almost the opposite, called the peroneals. Now, these muscles are stability and control muscles. So if you imagine you're walking on an uneven surface, maybe that is sand, maybe you're walking up and down hills with slightly uneven terrain underneath your feet, These muscles are working hard to contract and control the ankle. If these muscles are struggling to do so, we can often then end up rolling the ankle, which is a common hill walking or hiking injury. Finally, then at the back of the shin, we have our biggest set of muscles, which is the calf muscle group. These are the muscles that work hardest when we're standing and walking. And these are the muscles that are responsible for propelling us forward each step that we take. So when we get to the exercise session later on, I have some sample videos to try and target some of these key muscles because they are responsible for our movement and they do work very hard when we hill walk or we walk for any sort of prolonged duration. So we mentioned there that these muscles have different roles. We also mentioned that they can work quite hard, but I thought it'd be interesting to review and see how hard they actually work, because walking is a task that we might take for granted because we do it every single day. But when we walk for a prolonged period or when we walk up and down hills, it is a taxing task on the lower body. So there has been some interesting studies that try to quantify the loads and the demands on the different joints and muscle groups. The first line you can see here quantified how much work is done at the ankle or how much body weight is absorbed at the ankle during walking on a flat surface. And this study showed that it can be up to 5 times your body weight every step that you take on a flat surface is exposed to the ankle joint. If we shift our focus higher up to the knee, we can see a similar pattern that the knee is responsible for absorbing 2 to 3 times an individual's body weight when walking on a flat surface. Now, when we start to walk uphill or start to walk downhill, those forces can change and the contribution of different joints can change as well. So for example, when you're walking downhill, we place greater demands on our knees and our quadriceps muscles because on our way down a hill, the knees and the quadriceps are absorbing the force to slow us down and act like a brake system for the body. When we walk uphill, we have less work to do at the knee joint, but we have more work to do at the ankle and at the hip joint. It requires more energy to propel ourselves up a hill. And the main movers for this are the calf muscle and the big muscles around the hip, like the glutes and the hamstrings. Often what we'll see in the clinic is that people get this balance slightly off. So they'll come in and they'll have got the load they're placing on their body a little bit too high, and their physical capacity is maybe not quite able to match that. An example of this might be is that the demand they're placing on their body in terms of walking volume is the same that they've always done. However, the aging process is taking effect. So it's taking them longer to recover between walks. They're losing muscle strength and endurance, and they're maybe losing aerobic fitness. So what we might focus on next then is what, again, you can do from an exercise standpoint to keep yourself physically prepared for the amount of walking and hiking that you might be doing. So we have a series of exercises here. There's 6 videos in total. Each of them are going to focus on a slightly different joint or a slightly different muscle group, but they're all the muscle groups that we discussed earlier that we know are going to work hard when we're walking for any prolonged period. So these first 2 exercises are focused on calf muscle strength. So the first exercise on the left here is a seated calf raise. So we can see here you're sitting on maybe a kitchen chair with your foot elevated onto a step or onto a book with a heavy weight on top of your knee. That is a 30-kilo kettlebell on top of Niall's knee here. And what we're trying to achieve is that the calf muscle is responsible for driving that weight up and down. On the right-hand side, we have a standing version of that exercise. You can see how this might closely mimic the demands of walking up and downhill. What we want to make sure is that the calf muscle is primarily responsible for all of the movement here, and we're minimizing the work done at the knee or higher up at the hip. So we're focusing on slow and controlled movements, making sure that the calf muscle is having to work hard to generate the power. The second 2 sets of exercises are focusing on more of the smaller muscle groups that are responsible for stabilizing the ankle and responsible for supporting the bottom of the foot. So the first exercise here, we have a single leg balance exercise. This exercise is to try and place demand on the muscles either side of the ankle that play an important stability role. So we can see here, standing on something slightly unstable, So this could be, for example, at home, a cushion or a pillow. And we're trying to create a little bit of instability. And we're trying to work the muscles either side of the ankle to maintain a neutral or a flat foot. On the right-hand side here, we have an exercise that's designed to try and build strength on the muscles along the sole of the foot. So we have a band tied around something like a banister and then tied around the top of the big toe. All of the weight is then on one leg, and it's up to the muscles along the sole of the foot to generate power to pull the band downwards. And after 10 to 12 repetitions of this, we should start to feel muscles along the sole of the foot and along the arch become fatigued. If we were to shift our focus slightly away from the foot and ankle and move up the chain towards the knee, the quadricep muscles, and the hips for the hamstrings and glute muscles, we have two exercises here where you might get a lot of bang for your buck. So the first exercise is a split squat. So you try and split your feet apart, have an extra bit of weight over the front of your body like a kettlebell or a dumbbell. And what we're trying to do is almost mimic the demands of walking downhill. So we're trying to go slow and controlled on the way down and make the quad muscle on the front of the leg work hard to control that motion. And then we're demanding that the quad muscles and the hip muscles drive us back up to the top. And the final exercise we have here is a hip thrust. So you can set yourself up with your shoulders onto a couch, coffee table, or a bench, all of the weight on one leg. And what we're trying to achieve is that the back pocket and the muscles in your backside are responsible for lifting you upwards towards the sky. And after 10 to 12 repetitions of this, what we should start to feel is the back pocket region starting to fatigue. So there we have 6 exercises, which ultimately could be done probably in about 15 to 20 minutes. We're focusing on the main muscle groups around the foot and ankle, main muscle groups around the knee, and main muscle groups around the hip that are responsible for prolonged walking and responsible particularly for any sort of up and down hill walking. So a question we'll often get is, how often should I do this and how much should I do it? Is more better? And not necessarily. The goal of these exercises is to progressively strengthen these muscle groups to help the joints that are working hard during walking. If you do these exercises every single day of the week, one, you might be eating into your recovery time between your walks and finding that you're actually quite tired when you start your walks. Or two, you might be underdosing yourself a little bit, meaning that you're not making the exercises hard enough to actually see the benefits of it. So the way we tend to move now is we recommend that people do it on a 3 days a week basis, which could be every second day or every third day. Each exercise there, we'd recommend that you do 3 sets on left leg and right leg. And then within each set, we're looking to complete about 8 to 12 repetitions as a guideline. When you reach your last repetition of each set, it's important that you're feeling like the muscle that you're targeting in the exercise is getting to a near maximal fatigue state, meaning that if you hit your 12th repetition, it should be close to your limit. If you feel like you could go to 20 or 25 repetitions, again, you might be underdosing the exercise, meaning that it's not challenging enough for you to actually get stronger. So we would focus on 3 days per week, 3 sets each exercise, and making sure the dose or the demand in that exercise is strong enough for you to actually see an improvement. So that is a brief overview of managing your risk of injury for any walking, hiking, or hill walking. As you can see from today, it's a combination of education around managing the demand you're placing upon your lower body with your training, and then making sure you're meeting the physical capacity for that level of training. If you have any questions, I'm more than happy to answer them now in the Q&A session. If you're interested in maybe getting assessed or working with a physiotherapist or a strength and conditioning coach, the number for the sports medicine department is on the screen there, and we are accepting referrals.
David, thanks for a really interesting talk. So we have questions coming in now. So let's go start with Dermot's question. What advice recommendation would you give in terms of managing ongoing sciatica when walking or hill walking?
Yeah, that's a good question from Dermot. My main piece of advice initially, and I'm not sure if Dermot has already explored the sort of diagnostic side of things, because Sciatica is a term that's used to refer to pain that kind of stems from a specific nerve root. If he hasn't had any investigations previously in terms of MRI scans, it could be a useful tool, because based on what's found on the MRI scan, there could be different treatment options available to him to manage that. So, for example, if it was found on his MRI scan that there was a disc which was impinging the nerve root, sometimes an injection can be of benefit there to reduce pain and symptoms. The second thing then would be to, it probably alludes a little bit to my presentation earlier on, at having a look at what he can control in terms of his walking and hill walking level. So, for example, looking at how often he is walking, how far he's walking, and what sort of terrains he's walking on, because those things are going to increase the demand on his body. He may or may not need an extra day or two between walks to be able to recover and then go again. So for my main advice for him would be try and get to the bottom of what's causing the sciatica in the first place. There might be different treatment options that are available off the back of that once you have a clear diagnosis and a clear cause. And then once you have that clear diagnosis and cause, maybe we look at the training variables in conjunction with a physiotherapy program to continue to manage this long term.
Great, thank you. Question from Brenda. ACL tear, seen an orthopedics consultant 2 months post-injury, not going to have surgeries discussed with the ortho as it's not an unstable ACL, but any advice on rehab?
Yeah, I mean, if you've already discussed and reviewed with your orthopedic consultant and agreed that you're going to go the conservative route rather than the surgical route, that's fine. The rehabilitation should largely look the same as the surgical route as well then. It's something we see quite an awful lot of at SSC Sports Medicine. We have a huge amount of ACL injuries that come through our doors every year. And off the back of that, we've been able to develop a system for testing and rehabilitating these injuries. So that might be a first port of call, is maybe to look into attending SSC for a testing session. The information that comes from that testing session then can really inform what you need to focus on the most in your rehabilitation. And these could be things like improving your range of motion, improving your strength of key muscle groups around the knee, and then also the stuff we discussed earlier on around managing the amount of load and training that you're actually doing to keep the knee comfortable and keep the knee happy as well.
Lovely, thanks, David. Question from Mary. A lot of pain in the ball of my foot. I've been trying physio with lots of stretches of the toes and arches, but after 6 months still have pain. Any advice?
Yeah, this is probably a common scenario that a lot of people end up, and they come through our doors where they've been doing something for months and not really getting any success with it. It sounds like Mary is doing quite a lot of things for it in terms of stretching and different stuff, but one thing that may be missing from that is maybe a strengthening component. So for example, when we're standing and when we're walking, our foot is the first point of contact with the floor, and it actually takes on a huge amount of strain and a huge amount of weight bearing, and all of the stretching in the world might not be able to help that. It might actually need some strengthening exercises for the key muscles around the foot. The second thing I might say is if it's pain around the ball of the foot, but again, you're maybe not exactly clear on what's actually causing that pain, there might be a role here to see either a sports medicine doctor or a physio to help with the diagnosis piece. Because if you have the diagnosis correct, it helps you to manage or devise a management plan for it.
Yeah, lovely. Question from Fiona. Why do I suffer from shin splints when I walk fast?
So shin splints is a kind of like an umbrella term for pain around the shins, and it can be, again, a few different things. So for example, it can be bone stress related. So it can be a bony stress response, or even progressing sometimes to bone stress fractures. It can also be things that are maybe a tiny bit less sinister, like an overload of the tendon structures that stem from the shins. This is often called tibial stress. So first of all, again, it might go back to the idea of maybe being assessed by a physio or being assessed by a doctor to come up with a clear diagnosis. Because when you have that diagnosis correct, you can then decide what needs to be done to manage it. When we walk fast, if you can see from my presentation earlier on, whenever we walk fast or ever we walk up or down hills, the demand on the muscle groups and the tendon groups around the shin can really increase. So there may be a role here for strengthening the key muscles around the kind of lower part of the shin, foot and ankle region as well.
Lovely, thank you. Someone's Faith here is asking, a few other people are asking as well about copies of the leg and foot exercises. So we are going to, once this is over today and the whole webinar is finished, we will have it on our website in the next few days. So you can go in and look at it at any time. And also one of the tabs there is download exercises. So there is some exercises on there as well. So there's a question there from Faith as well. Any management for plantar fasciitis after hiking and how to avoid it?
Yeah, so plantar fasciitis is essentially an overload of the plantar fascia where it inserts onto the inside aspect of the heel bone. And it can vary a little bit. Sometimes it can be an overload and an inflammation of those tissues. Sometimes it can be small micro tearing that occurs in that region as well. So depending on what's seen, maybe on diagnostic scans, there is a role for an injection followed by a period of offloading in a walker boot. If there's no tears, usually this is rehabbed conservatively just through exercise. And again, it might come back to trying to progressively strengthen the muscles around the foot and ankle, as well as managing the amount of stress and strain you're at. All of the strengthening in the world might not help if you're continuing to overload the structures and not allow them to actually settle down. So it's a little bit like the slide on my presentation today, where you're trying to manage the amount of strain you're putting on it, and you're trying to maximize the amount of stress that these structures are able to undertake.
Yeah, lovely, thanks, David. Question from Judy. She osteoarthritis in both knees, and such exercises like lunging. Could she do squats instead? She finds she's difficult doing the lunging, or can you suggest alternative to lunges?
Yeah, so good if you have osteoarthritis in any joint. Strengthening is one of the kind of key cornerstones to managing that long term. So it's good that she's trying to lunge and thinking about doing these things. Lunging is really an exercise to try and improve the strength of the quad muscle at the front of your thigh, and sometimes as well the glute muscles around your hip. So to an extent, it doesn't necessarily matter massively what exercise you do, as long as you're able to engage and strengthen that muscle. So if she finds, for example, squatting is a more comfortable alternative, but it allows her to strengthen her quad muscles, then that is a perfectly feasible sort of alternative to the lunge, and I'd have no issues with that.
Dave, I had surgery for a ruptured Achilles tendon in September. Do you have any advice on timescales for getting back into hiking and running? Any advice on rehab?
Yeah, this is an area I see an awful lot of, because my PhD is actually investigating Achilles tendon ruptures and how people get back to activity and sports following that. In terms of timescales, it can vary person to person, but in terms of getting back to running, I think a 6-month time frame is a realistic time frame for most people. That might be the average, and there's some people that are faster and there's some people that are slower than that. What I would put more value in is not necessarily the time that's passing on the calendar. I'd put more value on the patient, or the patient hitting key criterias that indicate they're ready to run again. And that might be at 4 months, that might be at 6 months, could be at 8 months. But having key markers that indicate you're actually ready to run again is what's most important, not necessarily the timescale.
Okay, thank you. I've got 2 questions here from Bruda and another from Barbara about how to avoid cramps after walking, or any advice for like tight calf muscles.
Yeah, cramps to an extent are a little bit unknown as to what causes them and what they really are. Years ago, it used to be thought that it was a dehydration or a lack of potassium, and everyone was drinking water and eating bananas, but it really doesn't really make a huge difference. The current thought process around cramps is that it's actually a muscular fatigue, so that the muscle cramps when it starts to reach a really fatigued state. So if you're cramping after your hill walk, or you're feeling really tight in your calf muscles after your hill walk, it's probably an indicator that these muscles have just undergone a huge amount of stress and strain, and now they're struggling to recover afterwards. So I would, if I was you, I would probably look at two things. One is, can I prepare my calf muscles a little bit better for my hill walking by doing maybe some exercises? And two, can I do things after my hill walk that make me recover a little bit better? So that might be, for example, eating, sleeping, and drinking well enough to replenish the energy that I've lost on the hill walk.
Okay, lovely, thank you. Another one about the Achilles here from Brendan. He's got problems with his Achilles tendon on his left foot. When it comes on after a hill walk, it takes quite a long time to heal and remains either stinging or sore. Can often reoccur after a few weeks, particularly after a challenging walk. Are there exercises or treatments that you would recommend?
Yeah, what Brendan's describing sounds quite like an Achilles tendinopathy. Hard to say without meeting him and going through it, but it sounds like what's called an Achilles tendinopathy. And this is when the Achilles has a painful response to the amount of strain that has been put upon it. And it usually presents after a bout of exercise, and sometimes even 24 hours after a bout of exercise. So the two key things for managing a tendinopathy are managing the workload smartly. So for example, if your tendon is struggling to tolerate a certain volume or intensity of walking, maybe trying to reduce that a little bit to keep it happier. And the second one then is to try and load the tendon using exercise. And that can be really guided by a physiotherapist.
Lovely. Question from Helen. What's the best way to handle a Morton neuroma?
Morton's neuroma essentially it's an inflammation of a small nerve that runs through the metatarsal bones in the foot. There's conservative treatments, which is, again, you can look at things like footwear. So there can be small changes in footwear, which can make a big difference, or small inserts into footwear, which can make a big difference. You can also use exercise as a way to try and alleviate that pain. There's slightly more, less conservative options as well, where you can have injections, and those injections usually are guided by findings on an MRI scan or findings on an ultrasound. So you probably have to see a sports medicine doctor to go down that route. They often work well in conjunction with one another.
Actually, someone did ask that kind of relates to that. Any kind of features or degree of support in walking, hiking shoes that are best to prevent injury, or?
Yeah, not necessarily in terms of preventing injury. So a lot of research has gone into what type of footwear is best for hikers, walkers, runners in terms of preventing injury, and no particular brand or no particular type of shoe seems to be the best or the top of the pile. There is certain shoes that might be better suited to you, and that depends on what activity you're actually doing. It can depend a little bit on your foot shape and your foot type. An example might be, if we go back to someone who's dealing with an Achilles tendon issue, they tend to prefer a shoe that has a slightly higher heel in it compared to a flat shoe, because the higher heel takes a little strain off the tendon when they're walking. So there's no brand or type necessarily. There might be a certain type that suits you a little bit better given your current injury.
Okay, lovely. Question here from Dave. Follow-up question on running after Achilles tendon rupture surgery. You mentioned key markers to indicate progress. Can you give examples of those markers?
Yeah, so some of the key markers would relate to, for example, flexibility and mobility. Another key marker would be around calf muscle strength and calf muscle endurance. And then finally, we'd put some value as well in what we call reactive strength, which is really almost like a power measure, where you're using the calf and the Achilles a little bit faster and more explosively. And that would kind of paint a picture then that the Achilles and the ankle is ready to tolerate running again, rather than kind of, I suppose, rolling the dice and hoping for the best. And that's something I see personally a lot of in the sports medicine department. And we have the testing infrastructure available if he was interested to come in.
Okay, lovely. Question from Deirdre. She still gets pain 6 months after losing crutches. That she had a screw fixation in her fifth metatarsal, where she had a break. No, she did physio religiously for 3 months once losing the crutches, and then stopped. Should she double down and get back to exercise if she's still in pain? She was in a boot for 3 months prior to surgery. So it sounds like 6 months she's been in the boot and doing physio. Would you suggest she?
Yeah, I think like those fractures at the base of the fifth metatarsal can be really tricky. So like that's not an uncommon scenario Deirdre finds herself in. Main thing would be guided by her orthopedic surgeon, that they're satisfied with the healing and they're satisfied with the actual fixation of the break itself. And then definitely when you've been in a boot for 3 months prior to surgery, 6 months in total, what happens is the foot becomes sort of used to not having to weight bear a whole lot. So you lose things like muscle strength. Even the bone strength can be compromised a little bit because it hasn't had that weight bearing stimulus. So exercise really is your sort of key to getting back to your normal life there, in terms of bone health, in terms of strength, and muscle health as well. So I've definitely looked to start your rehabilitation again if you've stopped, but maybe be guided by a physio through this process again.
Okay. Any tips for recovery after a long hike? I think you did speak about hydration and etc. But anything else, David, before we sign off?
Yeah, I think the big things when it comes to recovery, one is sleep. Sleep is where the body really recovers and repairs itself. So making sure you're getting good quality sleep. Secondly would be your hydration and your nutrition, so making sure you're replenishing the kind of energy that you've spent on the hike itself. And then you can look at other sort of, I suppose we call them adjuncts to help, which might be things like foam rolling, stretching, massage, and all these other things. But it's hard to do those things if you're not sleeping, eating, and drinking well enough in the first place.
Lovely. David, thanks very much for joining us tonight. You answered a lot of questions there. So our next presenter now is Professor Brian Devitt, and Brian's going to talk about staying on the right track with osteoarthritis of the knee, and Brian's going to join us after his presentation. Thank you.
Good evening. My name is Brian Devitt. I'm going to speak to you on staying on track with knee osteoarthritis, and this is with relevance to walking and hiking. So I want to first off show you a picture of a former patient of mine. This is a lady who's in her 70s, and we have embarked on a charity walk in Vietnam. So she had previously had total knee replacement 18 months ago. So there's a few features I just want to point out. First of all, she's smiling. So she's doing very well following her knee replacement. Secondly, she's using a stick to help her get up what is a relatively steep slope. She's wearing the appropriate shoe wear. She doesn't have too much to encumber her in her hike in terms of carrying a lot of load, and she's willing to help or receive help from our guide who's bringing us along. So in Vietnam, we learned an awful lot of things, but one of the most important things we learned is some quotes from Confucius, who was a Chinese philosopher. And he told us, it doesn't matter how slow you go as long as you don't stop. And I think this is hugely relevant when it comes to the management of knee arthritis, but also activity in the setting of arthritis. It's really important that we keep on going. So we all come in different shapes and sizes, and it's the same with respect to our knees. We look here on the left side of the screen, we see what is a normal alignment, just two straight legs. We see a varus alignment, or what we know as bow-legged in common parlance. And we also see a knock-kneed or valgus alignment where on the right-hand side of the screen. Now, all people come in these different shapes normally, but when it comes to pathology, we also see people develop these shapes of the knees as time goes on. And this is quite relevant in terms of how the weight when we walk goes through our knees. When we're in a neutral position, the weight goes directly in the middle of the knee, which is equally shared. In this bow-leg position, the weight goes on the inside of the knee, and in this knock-knee position, the weight goes on the outside of the knee. So this has an impact in terms of how we progress with wear and tear as life goes on. So I'm going to show you a few picture examples or X-ray examples. And one of the things we use as orthopedic surgeons to diagnose arthritis, it's key to take the history from the patient as to where the pain is and when it occurs. But an X-ray is very helpful. The most important thing about the X-ray is the person is standing. And we can see on both legs here that there's very little space on the inside of the joint, both of the right leg and of the left leg. And we refer to this as decreased joint space, or also what is known as bone-on-bone osteoarthritis. So this happens in a situation where someone has bow legs. We also look at the kneecap, and that's really important when it comes to walking, because as you walk down hills or downstairs or even upstairs, it puts a huge amount of stress through your kneecap. So it's really important that we would look at this. And this kneecap is not too bad. It's got a little bit of decreased space, but there's plenty of life left in that yet. We often get patients referred to us with an MRI scan, and MRIs will diagnose a lot of the soft tissue conditions, but we can also see arthritis. So I'm going to explain initially, we're looking at this MRI is looking at your knee from the front. So this here is your kneecap. I'm going to work our way towards the back. So anything that shows up as white on these scans indicates fluid or increased stress within the bone. I'm going to point that out as we go. So we'll work our way back through the MRI. It's a little bit shaky, so excuse me. And I'm looking at the fluid in the knees. We know that this knee is not in a great state. And we can see that the bone in this area on the inside of the knee is very white. And that indicates that this bone is under a huge amount of stress. And the reason it's under stress, and I'm going to go through that again, is because the meniscus, which is the shock absorber in the knee, has been damaged. So you see this black structure is the meniscus, and you see it's being jettisoned out of the side of the knee, and underneath you've no cartilage on this inside of the knee. And that's why a lot of people come to us thinking they have a meniscal tear, but in fact, the horse has long since bolted. It's arthritis is the situation. So this is how we see it on an MRI, and the previous X-ray that we saw where you bone-on-bone arthritis is how we see it on an X-ray. So we do use all of these modalities to diagnose the injury and the presence of arthritis. This is another X-ray which shows arthritis not on the inside of the knee like previously, but on the outside. And you can see the shape of the leg is different from the normal leg, which is nice and straight. We see on the outside of the knee, you have wear and tear here with extra bone forming here in this region here. And you can see there's bone-on-bone arthritis on the outside of the knee. We look at this example of the kneecap, we see that there's a lot of extra bone around the kneecap and no space between the front of the kneecap and the femur. So this is an example of someone who has not only wear and tear on the outside of the knee, but also wear and tear on the front of the knee. So you imagine they're going to have an awful lot of pain walking downstairs, kneeling, or any type of movement going from a seated to a standing position. So now we're going to have a little bit of physics to understand why we have pain in the knee when we have arthritis and we walk. And physics, so this is a pictorial example of Isaac Newton. So Isaac Newton discovered gravity, but he also discovered a lot of other important physics equations and theories. And one of the things that he recognized is that gravity has a huge part to play, but also within the knee, as we extrapolate that to the load going through our knees when we walk, it is very important. So if we look at just walking, the weight that goes through our knees, each individual knee when we walk is twice our body weight. When we walk downhill, that increases to 4 times our body weight. And if we were to run, that can go up to as much as 8 times our body weight. So that's why if someone might be fine while standing, but when they walk, the pain increases. It's because the load going through the knee also increases. So let's do a small little calculation. So we'll take a 100-kilogram male. So that's a big man, maybe carrying a bit of extra timber. So with 100 kilograms, that person walks downhill. 400 kilograms goes to each individual knee with that action. Now, if he was to lose a moderate amount of weight, which is 10 kilograms or 10% his body weight, which would take a bit of effort, he would find that 40 kilograms less goes through each knee as he walks downhill. So this is very important to remember in terms of the loads that go through our knees when we walk, and also as a means of treatment for arthritis, it's very important. So in terms of the injuries we get while walking, I'm going to give you a couple of examples of how to avoid injury to begin with, so you don't end up in my office at any time. The first of all is knowing your limits. So when we start walking, or if you've gone from a period of a sedentary period to an active period, it's important that you go gradually. You don't go start hiking Mount Everest when you're just starting your walking. So it's very important to know your limits. I think that's one of the things we saw after COVID is when people were relatively sedentary, they went out to walking every day of the week. We saw people with a lot of issues develop quite quickly. So if you're starting to walk, just start walking on the flat first. And if you want to then engage in some steps, that's appropriate if you've no pain, or then walk up and down hills as you see fit. It's often best to be preconditioned. So you want to improve your ankle strength and balance. And nowadays we recognize that Pilates is really a great treatment for all types of ailments. And it's incredibly important with regard to improving your core strength, but also the strength of your quadriceps and hamstrings, and also your ankles. Particularly when you see performer Pilates, these can be very effective as an all-round holistic method to improve your strength. We recognize hugely, as I saw in the picture at the start, is that the use of hiking poles is really important, particularly when you're going up and down hills, because it allows you to take the load off the front of the knee and share it with the load in your arms. It also gives you an improved workout with your upper body. So using walking poles is actually very, very sensible when it comes to hiking. So that's something we would recommend, very much so. The use of appropriate footwear. So going hiking in a pair of sandals is not appropriate because you'll end up rolling your ankle or you'll load inappropriately, particularly on uneven ground. And that tends to put increased stress through your knees, or you've got a little niggle or some blisters that you'll walk a bit more, you walk differently, and that puts increased load through your knees. So that's a not a good wise thing to do, is to wear inappropriate footwear. And we recognize wearing properly fitted footwear with appropriate socks and trying to avoid getting the likes of blisters, because they do change your gait, and it's important that you try to maintain a normal gait, that you equally distribute the weight throughout your knee and not in one certain area. And then just common sense, hydrate adequately. When you're tired or fatigued, we tend to stress our knees quite a bit more. So just have an appropriately distanced walk, so you're not very, very fatigued at the end of it, or you're walking incorrectly, which puts more stress to the front of your knee. So it's really important that your general health is well maintained as well. So let's just look at arthritis. Unfortunately, if you can't avoid injuries, and you do get some injuries with arthritis, how do we manage them? It's really important that you understand this. So I like this quote from Macbeth, and I've used it before in different talks, where it speaks of eye of newt and toe of frog, wool of bat and tongue of dog, adder's fork and blind worm's sting, lizard's leg and howlet's wing, for a charm of powerful trouble, like a hell broth, boil and bubble. We got the lighting to come on as well, give a bit more impact. But this is a quote from Macbeth, but none of these things work for osteoarthritis. You can rest assured you don't have to have any far-fangled poisons or potions to get you to improve your arthritis. These things don't work. I oftentimes get patients coming into my room and they've consulted Dr. Google, and they come in and say, will this laser work, doctor? And really, I try to keep it very simple. There's a few tried and trusted things that work for arthritis, and I would encourage you to follow the tried and trusted and not the far-fangled treatment. So these are the treatments that do work. So physical activity is important, just like the lady who's walking after her knee replacement. Walking beforehand can be effective, but we try to avoid heavy load activities that put more stress to her knees. Weight loss is really probably one of the best treatments, but it's not an immediate treatment to lose weight. So weight loss is very, very helpful, as per Isaac Newton's knowledge and equations earlier on. Acupuncture has not been shown to work. Massage can be helpful for tight muscles. Bracing can occasionally be helpful, and maybe a compressive brace can give you a bit more feedback in your knee. Insoles, likewise, have not been shown to be hugely helpful, but they do make footwear fit more appropriately. And glucosamine has not been shown to be extremely helpful, but it doesn't do much harm and it's cheap, so I wouldn't be overly against the use of glucosamine as an oral tablet. We then look at pharmacological treatment, and we recognize that anti-inflammatories do work. So if you have swelling in your knee, it shuts down your muscles. So if we can get rid of that swelling, it allows your knee to function much better. A steroid injection can be helpful, particularly if you have swelling, but it's not a long-lasting effect. It just has a short-term effect. The use of hyaluronic acid in this recommendation, and that's from the American Academy of Orthopaedic Surgery, has not been shown to be effective. It may be more effective in younger patients, but not in patients with bone-on-bone arthritis. And then platelet-rich plasma can be helpful in some circumstances, but it's not the go-to in every case. And then we look at surgery. So what's stuff that we do as surgeons? So washing the joint out with the camera, that is not effective. It used to be an old-fashioned treatment, but we don't do that anymore. Sometimes if people, even in the setting of arthritis, have a flipped piece of soft tissue like meniscus, remove that can give them some temporary relief, but it doesn't remove the arthritis. It just removes the soft tissue, which might be impinging or getting in the way. Doing an osteotomy, which means cutting the bone and changing the shape of the leg, can be helpful in certain cases. And then a joint replacement has been shown to be very effective in the right setting at the right time. So one of the take-home messages I always say to patients is your objective is to avoid people like me as long as you can. But when your arthritis gets worse, modify your activity. If you're doing things that are hurting you a lot, like walking downstairs or walking down slopes, then try to avoid that as best you can. And it's also important to maintain the strength of your muscles and do so in a manner that doesn't hurt you so much. So doing the likes of cycling, Pilates, swimming, if you have advanced arthritis, can be very good to maintain your motion. The use of anti-inflammatory medication is very important. There's a limited role for arthroscopy and knee replacement when ready. And when I tell patients they know they're ready when they have pain at night or pain at rest that really affects their quality of life. And that's really important. So I'm just going to give you an example of this is a knee replacement. So this is one of the ladies earlier on who had the wear and tear to the outside of the joint and the front of the knee. And this is what we did. We gave her a knee replacement. And this lady was back walking and hiking. And it's not quite the picture of the one woman I saw at the front, but very similar, back to a very active quality of life. We see how straight we get the leg afterwards. And this is replacing the kneecap that was extremely badly worn with a resurfacing of the kneecap or patella, as we talk about. So it allowed her to walk downstairs without any major problems. We also sometimes just replace one part of the joint. So on this right leg here, we see the inside part of the joint has arthritis and decreased joint space and extra bone here. And in this case, we just replace this side because the rest of the side was relatively well maintained and allows patients to get back to a very good level of function very quickly after surgery. So patients often ask me, how active can I be with the knee replacement? And I often remember a patient of mine who was a farmer from an area in Victoria when I was working in Australia called Gippsland. And I remember this patient came in and he came at 6 months following surgery. And I asked him, did his knee hurt? And he said, occasionally it hurt. I said, when does it hurt? He said, well, after shearing 50 sheep, it became a little bit painful. And he told me a very good quote, which I often tell patients when I see them in the clinic. And what he said was, I quickly realized that it was a case of my knee getting used to me and not me getting used to my knee. So this is a real paradigm shift in my mind, in that when you have a knee replacement, just go off and do what you want to do. If you mollycoddle that knee and if you don't move it, your knee will be sore and stiff. You get off and do what you want to do, whether it's cycling, whether it's playing tennis, whether it's surfing, whether it's shearing sheep, just do what you want to do and your knee will follow suit. So I'm very happy to take some questions later on, and I hope you get back on track with knee arthritis. Thank you very much.
Brian, really interesting talk and loads of questions coming in. So let's kick off. First question from Trina. Why do I have discomfort in my groin while walking?
Well, it's quite common to get groin pain while walking. I suppose it depends on the patient's age, but typically if someone has pain, it's either a muscular injury or strain, or it can relate to arthritis. It's a very common site to get arthritis within the groin. And it's typically a pain that comes on after exercise. And as it gets more severe, you can get it at rest or at night. And that's when you really should have something done about it.
Lovely. Question from Anne. Is walking stick helpful with hip issues for walking?
Yeah, walking stick can be very helpful. Essentially, it's typically used in the opposite hand, and it is essentially offloads some of the weight going through the hip. And the muscles that are attached to the side of your hip really undergo quite a bit of stress when you have arthritis, because the joint is irritable. And this is an ability to offload that by using the walking stick, but on the opposite hand typically.
Okay, so I'm just going to go to one then about the walking poles. Are they a good idea?
Yeah, for the same reason, walking poles are an excellent idea. People tend to use 2 poles nowadays. I know the picture I showed at the start of my talk was just a solitary pole, but to use 2 poles, I think they refer to as Nordic walking, where they use 2 poles is great because you are able to, particularly going uphill, but also going downhill, you're able to take some of the load off the front of the knee. So you use your arms to push you up and you keep the stick and quite vertical, and it allows you to exercise your upper body, but also offload the knee and takes a lot of the stress off the front of the knee and makes it somewhat easier.
Lovely. From Nolan, how influential do you find excess weight has with the level of general inflammation of the body and when it comes to pain with osteoarthritis?
Well, as I referred to with Isaac Newton and the importance of gravity and weight is hugely important in terms of the load going through a joint. So not just your knee joint, but all your joints of your body. So if you're carrying excess weight, you will put a significant amount of weight, multiple times your weight through that joint. In terms of excess weight and inflammation, I think the excess load is going to give rise to further inflammation within your joint. I know there's further studies that probably have looked at obesity and inflammation in general, but specifically with the joint, it's very much the load that goes through the joint causes the irritability.
Yeah. What is the best type of knee support to wear, or would you recommend support or not?
Knee supports can be helpful in certain circumstances. I think, you can go from very fancy braces which offload one particular compartment of the knee, and they can be somewhat awkward to wear, but can be effective, to a simple sleeve, which essentially can give some feedback, or what we call proprioception, is where knowing where your joint is in space. And sometimes you have swelling in a knee, using a compression compression sleeve is very effective. But there is no proven evidence that they're going to reduce the progression of arthritis. They just make you feel a bit better during exercise sometimes.
Okay. A similar kind of question from Fiona. She's asking about jumper straps for pain in the knee. Find that she still gets the pain whether she uses it or not. So would it be better that she just doesn't use it, or why would that be?
Yeah, I think the jumper strap refers to the strap that just goes at the bottom end where your patellar tendon attaches to your tibia. That's where I see it frequently. I think the whole idea is of trying to offload the tendon somewhat and to take the stress off it. Really just using common sense. If it's not that effective, I'd stop using it, to be honest with you, and maybe have to look a bit more deeply into the problem.
Okay. So this is asking, what's your view on stem cell injections for osteoarthritis for the knee?
I just think we're not there yet. I think realistically with stem cells, they offer a great possibility perhaps in terms of the management of arthritis, but we really don't have the answers yet. I'd follow the research quite closely on this issue, and really we don't have the evidence to support the use of stem cells. One of the things which is very interesting, some of the guidelines from Australia where I worked previously, they said that you shouldn't really be involved or go to someone who is delivering stem cells without it being involved in a randomized control trial. And you'll find that most of the people who supply stem cells are doing so for a commercial gain. It's not based on research or evidence. So I would say beware in those circumstances, because you can find yourself out of pocket a lot without any proof.
It's reliable data. How important are those things?
Yeah, I think the use of iPhones, or what's referred to as disruptive technology, is very interesting and quite promising. I think that most people now have some form of iPhone or a watch, a smartwatch, and it allows us to be able to monitor our steps. I know there's some great research coming out of DCU in the Health and Human Performance School, and they're looking at the use of iPhones with runners and with walkers, and just to monitor their steps, but also an ability to monitor injury, or certainly low load injury, to see if that progresses to more serious injury. So I think watch this space is what I'd say. I think the technology is improving.
Great. Helen said, is it possible to get back to walking and hiking after bilateral hip surgery?
Yes, absolutely it is. Yeah. I think, hip surgery, nowadays we get people back to a very good level of function, and both hips, there's no reason you can't get back to it. I think one of the things you have to do firstly is get your normal gait pattern and improve that following surgery, because it can take some time, but definitely get back to activities and start on a flat and then increase the inclination and then go to hikes, more difficult gradients as time goes on, but there's no reason you can't.
Yeah. Lady Grania has osteoarthritis in both knees. Does hill walking make this worse, or is it okay to continue?
Well, I think hill walking is going to put more load through an arthritic knee, so it's probably going to make the pain somewhat worse. I think once again, just using your common sense, if you can maximize your potential in terms of keeping your body weight down, recognizing that if your knee is swollen or very sore, you're probably best not going for a long walk, because you'll be in further pain that evening. But if you're managing okay, and if you can alter the gradient accordingly based on your symptoms, I think you can continue walking. But also be aware that don't be foolish about it. If your knees are hurting you, that you can't get a good night's sleep, there is a solution for that, and that's something that I would seek professional advice from a GP, physiotherapist, and ultimately a surgeon if that is deemed warranted.
Okay. Linda's saying, what causes creaking in the knees, and can anything be done to eliminate it?
So creaking is very common in knees, and it increases with age as well. I think one of the things we recognize is people sometimes describe this crunching at the front of the knee, particularly going up and down stairs or getting up from a seated position. And what I make the analogy, it's like having two pieces of Velcro and those pieces being put together. So you've got the intertwined fibers of the Velcro, and as you pull them apart, you get a crunching sensation with the increased friction. And that happens exactly the same in your knees. You have two pieces of cartilage. The cartilage becomes soft, and the cartilage interdigitates with the cartilage on the front of your knee, the kneecap cartilage with the front of your knee, and that's what gives you that kind of crunching sensation. So crunching in and of itself is it just, I suppose, heralds the fact that you have soft cartilage. It's not necessarily a bad thing if it's not hurting, but it probably is going to progress to painful knees ultimately. But once again, as I said, the same advice applies: keep the body weight down, keep your activity up, keep your strength level good.
Question here from Emily. She's got knee osteoarthritis. She has lost 5 stone in weight, and she does a lot of walking. She wants to start jogging. Is this safe to do, or will she do more damage to her knee? It does ache after a brief jog.
Yeah, I think, you know, it's a fantastic achievement. First of all, losing five stone. That equates, as I said, to when she's jogging, that equates to 40 stone less through each knee when she jogs. So that's an amazing achievement. I think, you know, it depends on what her baseline weight is to start with. I think that, you know, jogging is going to put more load through your knee, so it may cause more pain. But equally, then you can look at different types of jogging. If you jog, you can do aqua aerobics. Aqua jogging can be helpful. That takes your body weight away immediately. But doing some short jogs, starting off with short distance and progressing up, and don't do them day after day. If you want to do them maybe on a weekend or a short park run or something, that might be a good goal to set. But really just monitor symptoms with time. And at the end of the day, your body will tell you if you're overdoing it ultimately.
Okay. Question from Veronica. She's had cartilage repair previously, now having problems with the knees again. She's had cortisone. She's awaiting MRI. She's asking, is knee surgery inevitable, or can pain successfully be managed by exercise? And is it okay to then to continue with the walking or hiking, or will it cause prolonged problems? Now, you've answered some of that there, but is it, I mean, talk about how she can manage it with exercise probably.
Well, I think, you know, knee surgery is certainly not obligatory, and it's not inevitable for every patient at all. And in fact, I tell patients to avoid knee as long as they can. And there's a fantastic, you know, group of physiotherapists and exercise physiologists who give exercise prescription, and they give a really bespoke treatment for knee arthritis, and that they deal with all of the issues, as I mentioned, in the factors that work. So they'll help you with your weight loss. They'll give you exercise that doesn't cause pain. They'll recommend specific, you know, strengthening exercise that you can manage, and they'll get you doing social exercise because it's very good, not for our physical health, but for our mental health as well. So, as I said, surgery is certainly not inevitable. You know, as the conditions progress, surgery may be helpful, but I would recommend people avoid it for as long as they can when it comes to knees.
Yeah. Question from Len. He does have bone knee issues. Not bad enough, he says, for surgery yet. He struggles to hill walk. He manages the gym 3 days a week. Knee is obviously still not improving. Any advice on getting back to the hill walking?
Yeah, it's a difficult scenario. I think, you know, I suppose we're on a hill walking webinar now, so I'm not going to diss it, but hill walking does put a reasonable load through your knee.
Yeah.
And if you're having a lot of pain, you have bone arthritis, and hill walking is affecting your quality of life, maybe doing something else in the hills, like cycling, might be better for the time being. But you really should seek kind of advice if you can do something to help you get back to hill walking. And that may require surgery. That might be what you're looking for. And there's lots of procedures we do. I think, as I mentioned in my talk, not all knee surgery relates to total knee replacement. We do partial knee replacements. We can do osteotomies where we put the bone. So getting a consultation and having an assessment is probably the first step in getting back on the trails, I would say.
Okay. Bursitis. I've ischial bursitis, which is worse after hill walking, and very uncomfortable when I sit down. Any advice?
Yeah, so ischial bursitis relates to the sit bone, as they talk about in Pilates. It's where the bone on the back of your pelvis, where your hamstrings are attached. And typically, ischial bursitis goes hand in hand with hamstring tendonitis or tendinopathy. And it's not uncommon to get in runners or in hill walkers because you're in that flexed spine position, which puts a lot of strain on the top of the hamstring. So sometimes it just requires rest or strengthening of the gluteal muscles. Other times it might herald a tear, which can occur as we age. And sometimes it can tear so much that the hamstring pulls off. And that's a situation that may require intervention. But an MRI scan is normally able to diagnose that pretty well. And really the early treatment is mostly strengthening.
I've got 3 questions here about knee replacement. One, someone they're asking about the success of the knee replacement, and then someone else about how long rehab takes after the knee replacement. I think the 2 of them maybe some tie in together as well. And is it possible to get back to running after the knee replacement?
Yeah. So I suppose let's deal with the first one first. How successful knee replacement? It's very successful for the vast majority of people. And if you take 100 people who have a knee replacement, you'll find 85 to 90% of those people will be very happy. You'll find that probably 5 to 10% will have some lingering pain, and you'll find 5% of people probably won't be happy, will have ongoing pain. And typically those people who have ongoing pain, either their condition is not solely related to their knee, or perhaps they just haven't rehabilitated properly. They've got stiffness afterwards. In terms of your rehabilitation following a knee replacement, typically you're using crutches for the first 6 weeks or so, and then you're weaning off the crutches. You're getting back to driving typically at that time. People tend to have some discomfort at night up to 3 months. But before you're back to your normal level of activities, it's probably in the region of around 3 to 6 months. And before you recognize it or you forget you've even had a knee replacement, it can be up to 12 months following surgery. And then can you get back to running? Yes, if you wish. We wouldn't recommend you run an ultra marathon after a knee replacement because it's going to wear out with more activity. But you could certainly get back to kind of a little bit of a jog if you wished. But most people are kind of happy just to be able to do their regular activities. It wouldn't be the best exercise running. We'd rather you do swimming or cycling. But if you wanted to play tennis and stuff like that, or ski, that's fine too. We don't mind.
Can long-term knee problems cause back pain?
Yes, they can. Yeah. Unfortunately, with long-term knee problems, you tend to get a greater level of deformity. So one of the things you recognize the early signs of arthritis is you can't get your knee fully straight. And if you can't get your knee fully straight, you tend to stand with a more flexed posture of your hip, which puts more stress in your lower back. So that can also cause some lower back issues. So it really has a knock-on effect, not just in terms of your gait, but also your stance, and it has an effect on your back.
I was just asking here, how long does a knee replacement last? Is it for life? And I suppose that depends on how old you are when you have it as well. So
yeah, so I was at a conference recently, and I was put to one of the speakers, and he probably answered it the best I've heard. It said there's probably a 1% failure rate of a knee replacement per year after it's been inserted. So if you have a knee replacement in for 20 years, there's an 80% chance you'll still have that knee, and 20% chance you might require a revision. So one of the reasons, as I said, we have to earn your knee replacement. We try to avoid it for as long as we can, especially in young people, because young people are going to use their knee more, therefore they're going to wear it out more, and therefore they're more likely to have a revision at a younger age. But I think our thoughts on this, we're kind of realistic as well, that we recognize that knee replacement is a good procedure. We want to avoid it as long as we can. But equally, life is for living. And if people have an awful lot of discomfort and can't play with their kids or can't do things that they want to do, we do have a solution, but we have to be very selective in terms of we choose it. And we have to make sure people are very aware that it might require revision at a later stage.
Yeah. And Brian, Helen here, she's got a torn ACL. She doesn't think she wants to go through surgery and recovery. Is there evidence that she may end up with arthritis in the future? She's 55, very fit, and uses the gym regularly.
So unfortunately, with an ACL tear or rupture, there is evidence that yes, you're at a greater risk of developing osteoarthritis. I think more pertinent is the status of the cartilage, so not just your articular cartilage, which is the hard cartilage, but especially the meniscus, which is the soft cartilage, the shock absorber between your knee. So if that is injured, that does increase the risk of arthritis. There is no evidence necessarily that doing an ACL reconstruction is going to reduce your risk of arthritis, but it does stand to reason that if it protects the menisci, then it can be protective in long term. But if it depends on what this lady's physical activity is in terms of what she wants to do. She's going to do sports or activities that require pivoting. She is unstable, that she has a subjective feeling that her knee's going to give way. She may benefit from intervention, but if she's not, then she could very well be very content without an ACL reconstruction and do extremely well.
Okay. Gráinne's just asking, is there an assessment you can get to examine the state of your knees and legs generally for returning to walking, and general level of fitness before they start again and maybe play tennis? So I suppose, how do they get their knees assessed?
Yeah, well, you can do that through a number of means. I think one of the facilities which I think is fantastic is in the sports medicine department at the sports surgery clinic. And they have a whole series of strength and conditioning coaches that do some objective strength testing and bring you through some flexibility assessment. They look at your running gait, they look at various different factors, and they can give you advice on strength and conditioning. If they feel it's necessary, they can refer you on to a physiotherapist, refer you on to one of the sports medicine physicians, and they can organize some imaging as well. So it's a one-stop shop in terms of looking at your general health and your general fitness and improving it. So I think that'll be a great place for that person to go.
Fine, thanks very much for joining us this evening. If anyone has any questions or wants to make any appointments, they can just hit the tab and you will get the link or phone number to ring or the email address, and we will come back to you. Thank you again for joining us, and our future events are on the website. Thank you.